Hi, I'm Dr. Rosie Roeder.
And I'm Andrea Spar.
And we're the Rejuvenates Podcast.
And today we're going to talk about more plastic surgery.
Yes.
Specifically, tummy tucks.
Yeah, fun stuff. It's one of my favorite surgeries to do because I think there's this immediate
change.
Change and satisfaction from patients.
Snatched. That was one of my favorite surgeries because if people don't remember, I used to work for this practice as a surgical tech in the OR with one of the founding owners, Dr. Ness, the plastic surgeon. So tummy tucks were my jam. I love tummy tucks. Mm-hmm. And yes, you get instant gratitude because once that pannus comes off and that waist gets slim, it is looking fabulous.
Yes, absolutely. So what is a tummy tuck? Right? Because people constantly ask me, what's the difference between tummy tuck and liposuction?
And a panniculectomy. We need to squeeze that in there as well.
Yeah, we're going to squeeze that panniculectomy in there. So a tummy tuck basically is an operation in which you're going to remove excess skin from the abdomen. And that's usually overhanging skin below the belly button. But some people have rolls above the belly button as well that will get addressed in a tummy tuck. And we are going to tighten your muscle underneath. Now, a panniculectomy is a procedure in which we only remove the overhanging skin below the belly button. It's not meant to address any skin laxities above the belly button. It's not meant to address the laxity of, the diastasis, which is the laxity of the muscles underneath. So a panniculectomy can be a medical procedure. And for some people, it is important to get that skin out of the way to improve rashes and wounds that can be created underneath.
Specifically things like intertrigo.
Yes.
Which is an overgrowth of yeast in those places that like to hold moisture from the skin hanging.
Right. And I get a lot of patients that want to have insurance covering their panniculectomies, and it's hard to get it covered, but the main thing about that is you need to have intertrigo documented by a medical professional, and that's resistant to medical therapy that you have adhered to over the I think time span of 3 to 6 months is what most of them want to see, that you've been treated for open wounds, for these rashes that have not resolved. The other instance that I'm able to get them covered is when a general surgeon or a gynecologist need access, meaning the patient's pannus is making them unable to access internal organs for a general surgery procedure or for a hysterectomy or another gynecological procedure. So I have in the past worked together with other professionals, and it's called an access panniculectomy. So we give access so they can go directly and put instruments into the patient's fascia to get inside the belly with either a robot or laparoscopic equipment. So very rarely do I get asked to do that, but I do, and it's definitely a medical indication.
And that's all done at the same time.
Yeah.
Correct. Yep. And then do you close or does the actual general surgeon close?
So it depends who I'm working with, but one of the general surgeons that I work with a lot of the time, he closes half and I close half because he's my buddy and he tries to help out. And he actually does a really good job at suturing. So sometimes I'm actually envious because I'm like, darn, like I'm supposed to be the expert here.
Perfect.
But he actually does a pretty good job. And we work together, not just in Hickory in the operating room and multiple different things, but we also go to Africa and do some charity work there and do some surgeries in Africa. So it's great to have partnerships with people that you can work consistently in different
environments. Especially in other specialties.
Yeah. But outside of these medical indications, it's a purely cosmetic procedure.
Yes.
And it's, again, very rewarding. And I have women of all ages coming to me. Not just young women, but the average, I think, age of patients I do this operation to is around 50, if you account for the women in their 40s that are done with their childbearing years, some in their late 20s. And I have had women in their 60s and 70s having this procedure done as well.
Now, have you seen an increase in people coming to consult since GLP-1s hit the market?
Yes, because they lose weight and that deflates their skin. So they definitely need to do that. But a lot of them need more skin resection than just on their abdomen. They need it all around in something that we call a body lift or a belt lipectomy, where you also need to take skin off the backside to lift their buttock and to address the flanks more adequately.
Or the upper part of the hip.
Or the upper part of the hip. And then you sometimes have to combine that with skin resection around their bra rolls in the back. And most patients on GLP-1 that have lost a lot of weight, and they deflated everywhere.
Yes.
So their arms, their legs, their breasts. I have a sequence in mind in which I like to do these procedures for massive weight loss patients. I like to combine arms and breasts and have patients have access to their legs fully so they can use them to get out of bed, prompt themselves and walk. And then I usually do the lower half, meaning the abdomen and the legs at the same time once their arms have healed, or let's say they're not bothered by their arms or their breasts, and they can use their arms to get themselves around, move up and down, get themselves out of bed. I think it's important to separate things. I think it's a lot of skin resection. People kind of underestimate the impact that can have on their body in terms of just fluid shifts, right? When you're taking skin and fat out, you're also taking fluid. You're taking vessels, blood vessels. So you can have a drop in hemoglobin. Your body's now trying to equilibrate over time, and we can't do too much at once. The amount of time under anesthesia to do all the skin resections is large. So we keep surgeries under 6 hours. And again, try to be very conscious, because not everybody is the same, about how much skin has to come out if we're combining it with liposuction, and what the fluid deficit is going to be, because we don't want people to be dehydrated.
Right. Because one little bag of fluids is not going to do it. And a lot of times these people go home, they've been under anesthesia, they just want to go to sleep, and they're not replacing that fluid in that first 24 to 48 hours, and that can be very, very dehydrated.
Right. And they can then pass out at home, pass out in the shower, pass out in my office the next day. So we want to make sure that we have them tanked up. We don't want anybody to be anemic. So this is a surgery where I absolutely need women to have a hemoglobin above 10. And you think, well, yeah, of course, doc, you want somebody with a normal hemoglobin. But a lot of women who menstruate sometimes do not have hemoglobins at the right level, or they don't even know that they have that problem until we do a preoperative check and their hemoglobin is a little low. So I make sure that they're tanked up, that they're on iron, or that they see someone if they don't have normal blood level counts beforehand to optimize them, because a lot of menstruating women having healthy periods, this is normal for them. Nobody ever checked. They're a little bit borderline, and they're definitely on the transfusion range, and their medical doctors just let them go. But when you're undergoing surgery, that's a different level of optimizing it. Yeah. Yes. And also hydrating before surgery. So our anesthesiologists are pretty good at calling the patients and saying, hey, drink some Gatorade, get yourself tanked up before surgery. So after midnight, we're going to tell you not to eat or drink anything, right? But up until dinner time, you should be loading up on some fluids ahead of time, just to have that good equilibrium and hydration, especially if you're not a water drinker.
Right.
And a lot of people don't like to drink water. They'll just drink their coffee all day, or an energy drink. Like, this is the time where you need to really have the water, have the Gatorade, the Powerade, Propel, whatever it is that you like, to replace some salts as well.
And then protein as well.
Oh, yeah. You need a lot of protein, especially if you've been on a GLP-1 where you do lose some protein mass, right? And that's a propensity, is to lose that as well. So you really want to optimize that. And you have to look at the weight loss patients and assess their albumin level, their pre-albumin level ahead of time, to make sure that they're going to heal well. So let's describe a tummy tuck, right? So you're going to make a incision that's hip to hip. And I try to bring it down above the like right around the suprapubic or pubic area, because I like my incisions low.
Right.
I'm Brazilian, so I think of the Rio at the beach.
The lowest bathing suit you can.
Lowest bathing suits you can. Skimpy
bring
bathing
in
suits,
their
right?
bathing suits. So they want to say, this is the bathing suit I wear most of the time. This is where I want my scar put, if you can get it this low.
Yes. And I ask people to bring that. If they do have a bathing suit, they like to do that. And I once did a tummy tuck on a person who competes in North Carolina for bodybuilding. Yep. And her main concern was to hide that scar. And I said, well, bring in your competition suit and I will mark your incisions within that competition suit. And she's been competing since, and nobody has seen that scar. And we fixed her diastasis because she's very lean and she had babies. So we fixed that, fixed her umbilical hernia at the same time. So she can look really snatched and make sure that the work that she was putting in was visible during these competitions. Right. So that was extremely rewarding, but it is difficult to do a tummy tuck with somebody whose percentage body fat is like less than 5%.
Right.
You know, very difficult, but it was amazing, you know, and having that healthy patient really helps. So you want to have also been close to your goal weight in your weight loss journey. So a tummy tuck, again, just like we talked about liposuction, is not a weight loss procedure. It's meant to take out the excess that was left after you've gotten close. I tell most of my patients I want you to be within 5 to 10 pounds of your goal weight.
Yeah, that's what I was about to ask. If they lost more weight after, would it even make the outcome better?
Yes. And people do lose weight after liposuction like I did. Mm-hmm. I had a liposuction procedure, and afterwards it got me so motivated based on what I saw to do even better. But I had already lost like 14 pounds ahead of that. I had the procedure, and then I lost another 14 pounds afterwards. So it can propel you to even further weight loss. The downside of that, if you have surgeries, that you might have a little bit more laxity that we have to correct afterwards. But hey, you know, that's not a big deal. Like if you got to where you want to be in your body and we were part of that journey, then fabulous. But you don't want to be 20 to 30 to 40 pounds overweight, because it's not going to help you, especially if you concentrate your fat intra-abdominal, right? So inside the abdominal cavity. So if you can pinch it, I can suction it. If you can pinch it, I can remove it.
Right.
But if you do that and there's still some fat that's inside your belly, I can't go in there and get that.
Now, does the muscle tightening help camouflage that as well?
The muscle tightening does, but I have rarely found anybody that has had more than a 1 to 2 inch diastasis. The average I get is 1.5 inches. Mm-hmm. So you tighten 1.5 inches, that doesn't necessarily, you know, make
help
that
push everything
significantly better. But that tightening of the abdomen is what leads to the biggest complication, I feel, that could be life-threatening in a tummy tuck. So if you squeeze everything back in, that puts pressure in your intra-abdominal organs, and what's going to take the brunt of that is your inferior vena cava. The inferior vena cava is the biggest vein that you have in your body that returns blood to the heart. So you can get what we call venous stasis. So a slowdown of the blood going through that, which can lead to blood clots in your lower leg. And those blood clots can travel into your lung and cause a pulmonary embolism. So I, again, talk to my patients a lot about hydration, about preventing blood clots. I personally check something called the Caprini score. It's a very well validated measure that assesses someone's individual risk of a blood clot. So our nurses during our preoperative visit go over that. If you are above a 7, then I'll give you anticoagulation. If you're below that, then we will discuss what the other measures are that will prevent it. If you're below 3, it's very rare. If you're in that in between 5 or 7, then there's a few other things that we can put into play to make sure that you don't run that risk. Have I had patients develop blood clots and a pulmonary embolism? I've had one of each. There were very special circumstances. One of them didn't know a past medical history. I do know some plastic surgeons that universally give everybody a blood thinner. The data shows that increases their bleeding risk from 2 to about 17%. So I prefer to be conservative because I don't want to put people at any other risks. But none of these is wrong. This is just different approaches to the matter. Mm-hmm. I think you just want to make sure you have that discussion with the patients and assess their risks and make sure that that's a good concern. And that hydration factor, that makes a huge difference. You know, you want to be tanked up, not just for the fluid shifts, but also because it decreases your viscosity of the blood. Like it's not as sticky.
Right.
So if you're well hydrated, that's definitely key.
So we've made the incision, we've opened up the area.
Yeah.
What are we doing next?
So we want to get to where your muscle fascia is. So we're right above the muscle. We want to lift all the subcutaneous fat off the muscle with your skin. We go around the belly button with the circle. So we release the belly button. In the majority of a traditional tummy tuck, I'll talk about when we don't do that in a minute. But we release your belly button so your belly button gets stuck to where it is. Don't go anywhere. That stock sits right there. And you elevate until you get to the xiphoid, which is the bone right below your breastbone. So you're going all the way up to the ribs. You're lifting up that skin, subcutaneous tissue. And then you have access to the muscle. You can see if there's that diastasis or that widening in the middle. And you tighten that. People do it in all sorts of different ways. All of them work.
Yep.
Or don't work to the same extent, right?
And there's different sutures you can put in that
There's different
too,
sutures you can put on there, but essentially the technique is the same, and the outcome on these individual surgeon variations I don't think really matter. And then once you've tightened that, I use Exparel, which is a long-acting local anesthetic. It lasts 3 to 4 days. It helps decrease pain. It helps people move. So if you're moving and you're walking, then you're less likely to get a blood clot. So I love using that. I use that in all my patients. I will do a TEP block, which also helps with postoperative pain. I'll put it on the incision. So people think that the surgery was actually a lot better pain-wise than they thought it was going to be, or they have heard because of that. And then what we do is we get you in kind of like a beach chair position, kind of flex you on the table, so we can bring down the skin as much as possible and take out all the excess skin and make it nice and tight. And then I will put drains. You can do drainless tummy tucks, and I've done them as well. And if patients request them, I'll do it. I just warn them that it could be a little bit more painful because of the stitches we have to put to close down the space to the fascia, which is where all the innervation comes. So traditionally, I'll do drains. Drains are your friend.
Yep.
They've never hurt
last
anybody.
thing you want is the seroma hanging out, because it's going to take longer for your body to reabsorb it than it just coming out of a tube for the next few weeks.
Exactly. And we'll talk about the postoperative care and the things that you can expect afterwards in a little bit. But yeah, drains are your friend. People are scared of drains, but losing a drain prematurely or having one pushed back in like somebody did the other day to me are actually not good things to do.
Right.
They can render some problems. So just if your surgeon wears drains, great. If your surgeon doesn't do drains, then great too. Just understand what the potential risk benefits of things are. But I do drains, and then I close it. I close with all internal stitches. You will never see a staple on any of my body procedures. I might put a staple somewhere in a scalp if I'm doing an endoscopic, like facelift or brow lift, but I don't do them in any body procedures at all. They'll all be internal stitches, and you won't see them at all. And I'll use a brown tape or steri strip on that.
I love the brown tape. I still use it on some of my excisions because I still run some stuff underneath for some people in areas that aren't pulling. And I'm like, this is the only wound care you need is this tape for the next few weeks. And they're like, really? And I'm like, yeah.
It's amazing, right? It's just like 3M brown tape.
Yep.
Simple thing. You put it across the incision.
And it's sticky. It'll stick.
It will stick for 2 weeks really well. And then you can shower with it in place even the next day. It's porous in a way that it will take moisturizing if you want to, but it's not going to cause any harm. It rarely traps any bacteria underneath. And then at 2 weeks, it usually comes off really easily without harming the skin. And then we'll start hydrating it for another 2 weeks, and then we'll do some scar gel. Belly buttons. Sometimes I can look at a cover of a magazine and see that somebody has had a tummy tuck because of their belly buttons.
Some people make the weirdest shaped belly buttons because they're just trying to make it back together to where it was. Yeah. Everybody in our practice, everyone I've seen looks really natural, the way, because everybody has their own technique.
Right. Yeah. I make my belly buttons small because they widen a little bit.
Yeah.
And I really am very I guess I ask a lot of myself when it comes to belly buttons, and if they don't look as good as I want them to do, I'm going to bed and not sleeping because I'm thinking about that belly button. I can think of one right now where she had such an outie that I was trying to make an innie, and so whatever people want, we try to deliver it to them. Some people completely eliminate belly buttons and make new ones for patients, especially if they're doing something called a fleur-de-lis. Mm-hmm. So a lot of weight loss patients not only need the vertical, but they also need the horizontal skin tightening. So you have to make an incision down the middle, which people accept really well when they have that laxity. And I have lots of plastic surgeon friends that just cut out the belly button and make a new one within that flap. I try to keep it because I like to keep people's stuff as much as I can. But that's just me. But if you have to remove the belly button, you can. And some of the panniculectomy patients, I've removed belly buttons and just done the panniculectomy and come back and done belly buttons later on them.
Now, there's a type of breast reconstruction that you can actually do a tummy tuck when you're reconstructing because you're using the muscle.
Correct. So that's called a DIAP flap. A deep inferior perforator flap is the most traditional one, considered like a gold standard in breast reconstruction, where you pretty much are doing a tummy tuck and getting that abdominal tissue, dissecting out the inferior epigastric vessels down to its origin and giving them some length. And then you bring it up to the breast position after a mastectomy. You got to make little windows around the chest to reconnect it with the chest vessels. And you get a tummy tuck out of it, kind of like. Most of the time that I've done it, we didn't tighten the abdominal wall for that. We just did the skin-only resection. But, some people like that idea. There's fantastic people in Charlotte, Winston, and Asheville, so around us that does that. Myself and Dr. Butala at one point thought about doing, like, we're starting a DIAP program, and we just found that based on the practice that we have, that's not something that we wanted to pursue at the time. It has to be very specialized. Goes to what I said in another podcast. You want to do something that you do consistently.
Yes.
Because it's, especially in specialized surgeries, it's not just about the surgery, right? Because anyone can do these surgeries really well. It's about the people that are taking care of you post-operatively, like the nurses at the hospital and the staff, and you want to make them trained. Like when I did these procedures at the Brigham and Women's Hospital, the patients would go to the floor. Mm-hmm. Because it was so commonly done. We did 3, 4, 5 a week of these free flaps that the monitoring, the nursing, it was all like, standard at this point that we can make the patient experience better. And if we don't have the volume to do that, and we were going to be doing just a few, like a year, it wasn't worth doing it. Just let the guys in Charlotte, in Winston, or in Asheville who do them a lot, do that.
Right.
Because that's what's best, for the patient. There's other types of pedicle flaps too that involve the tummy tuck, like a tram flap traditionally. But I think that if you have the opportunity to do a free flap as a breast recon patient, that's what I would say. And yeah, maybe your secondary benefit is a tummy tuck. But cosmetically, we don't do that.
Right.
Cosmetically, we're going to do a traditional TT. The surgery varies between surgeons, but it takes me on average about 2.5 hours for most patients to get that surgery done. I see my patients the next day to make sure that they're okay and just to clarify instructions, because as much as you talk to people beforehand about the surgery, the post-operative care, what's going to happen to them, I think it's really important to just kind of rehash that within the first 24 hours. And then you can also pick up on things early. So if there's something minor that could become a problem in the next few days or over the weekend, because I do most of my surgeries on Thursday, then I can pick that up early and instruct the patients. And if they need to go back to the operating room for whatever reason, and sometimes there are reasons for that, like bleeding, or which is the most common one within 24 hours, we can address that. Or a drain then like falling out or something, we can address that quickly. And sometimes you just want to ask questions that they didn't think they were going to have. But then we can address like showering and making sure that everything looks like the patients expect and like I expect, and then we can have peace of mind for the next few days. So I usually see them, post-operative day 1, and then I'll see them again to get the first drain out at about 7 days after surgery. I put my drains at the incisional ends. I don't like to make new holes. You have a big incision, we can use it. So I use it, I put it at the end, and then I just clip a stitch and it comes out. I use round drains. So they're the same size on the inside as the outside, so they slip out. Most people are very amazed that they didn't feel anything.
Right.
Or they was like, oh, that's weird, kind of tickle on the inside.
A lot of people hype themselves up for like post-procedural pain, and it's really not that bad.
Don't they?
Yeah.
They really do. And I mean, my team, and you were an MA as well with our surgeons at one point, but like my team is very skilled at removing drains, so that if I'm not in the office for whatever reason, I'm doing another surgery, or I just happen to not be in the office that day, I'm off site, that they can remove it, and it's not a big deal.
Staffs make or break you, because they, if you don't have good staff that can take care of these patients, then patients don't like it, know, and I think a lot of our staff work well. They can take out their sutures, they can do the drains, they can do minimum post-op care for you, especially if you're not in office.
Yeah, absolutely. I mean, I trust them with like myself.
Right.
I never refer a patient to my esthetician for a procedure that I wouldn't let her do on me. Just like I wouldn't let my patient have a drain removed by one of my medical assistants if I wouldn't trust her to have that do to me.
And I'll say, I trust this person with my life. I guarantee it. They've been working on me for 15 years at this point, and I'm still here, so we're good.
Exactly. So, you will get your drain removed at about 7 days, and then you will go home, and I'll bring you back a week later, and most likely the second drain will come out. The max of I have a drain stay in is about 3 weeks. After that, the drain becomes more of a problem than it helps. And if there's something still going on, like you're still pouring out fluid, then maybe we have to approach it in a different way. There are ways to use some medicines within that cavity to try to sclerose it, to decrease the fluid. And if we have to go back to wash it out, then we have to go back to wash it out or put some additional stitches. So, but that fluid is called a seroma, is what Andrea was addressing, earlier. A seroma is a natural healing process, really, that can become abnormal. So if you just open up all the space, then the way the body heals is by creating fluid. It is going to extravasate fluid from that. If that is more than the body can pick up, then, and you don't have drains anymore because your drains have been removed, or it's overwhelming your drains, then you're going to have an accumulation of fluid in a cavity. And that can cause pain, it can cause infection, it can cause the wounds to open because the body doesn't like that fluid, so it's going to find a way for it to come out. And this is why we put drains, actually, right? Because we know your body's going to be overwhelmed by that fluid within the first couple of weeks of surgery. So we got to let that drain out so you don't have problems. But if you do have problems and I have to take you back because we need to do something to the cavity, then so be it. But this happens very rarely, like 1% or less. And you can also drain fluid in the office percutaneously, so you can find where that space is, put a little X on there, numb it, put a needle in.
Do the little wave.
Do the little wave. Yeah, do the wave. I have ultrasound in my office.
I know, you're so lucky.
I can use, I have my own personal ultrasound, so I can get my ultrasound, look at that cavity and see if I have a target. And it's been really useful because I had a patient once where we were trying to figure out, is this just post-operative swelling or is there a seroma? And is there a drainable seroma? So having that ultrasound technology really helps distinguish that. And then with the ultrasound, we can look at it together. You can see what I'm seeing. I can show you. I can hold it. I can use my needle to guide me straight into that cavity as I aspirate and see that cavity collapse. And I've done this for, a lot of axillary procedures that I do, like lipomas in the armpits are notorious for that, or when we had some lymph node biopsies in cases occasionally of a tummy tuck or anything else. The ultrasound has been a really great thing to do and have in the office as a tool.
I know. I would love to have one just for like veins for like Botox and stuff. That would definitely be.
And fillers, right?
Yes.
So there's a mode for the ultrasound and it is beautiful. And there's AI technology. It gets the layers highlighted in color. So you can tell exactly where you are to inject that filler. It's beautiful. I love it.
I'm going to have to come to Hickory and play now.
Oh, yeah, sure. Yeah, I'll show you how to use it, or I'll come to you and I'll show you for that. But for breast implants too, the AI technology is getting there where they're going to layer in and almost just automatically tell you that the implant is ruptured. But it has really helped my patients with me not having to get excess imaging like MRIs. I can pretty much look at it and tell them like, hey, it's ruptured. And if I'm not sure, then I'll ask for the MRI and correlate it with that. But anyway, back to tummy tucks.
Yes.
So that's sort of the first 2 weeks. I think most people are okay going back to work and driving after about 10 to 14 days. Some of them don't like to go back with drains in place, and I'm okay with that. So I'm like, 10, 14 days off of work, staying at home is fine. You can cook. You can microwave stuff.
Right.
You can do some things around the house. I want you walking. I want you moving. We definitely don't want anybody lifting weights, nothing more than, 10, 15 pounds.
Yeah, we should tell people walk, eat, sleep, walk, eat, sleep, walk, eat, sleep. Because you're tired that first month. It takes a lot to get that energy back from where you went through this whole change.
Right. Again, remember that you have tissue that's been removed. You have fluid and blood vessels, and you've lost a little bit of that. And if you've never had anemia before, you've never had this kind of impact on your body, physiologically, there are things that are happening that your body has to adapt to. During this healing period. There is a pro-inflammatory response that's going on, so that wears you out. So eat well as well. Like sometimes people feel nauseous from the medicines, and I'm like, you definitely want to drink. Drink is the number one thing, but you want to eat, and you want to eat where your body's asking you to eat. And constipation. I'm constantly talking to my patients about that. You're going to get medicines during anesthesia that's going to slow down your gut.
And after to take home.
And then you're going to have your belly tighten. So that's going to press on your gut, right? It's already uncomfortable. You don't want to add insult to injury. So having a good bowel regimen is very, very important Very important. It's okay if maybe you didn't go number 2 for about 3 days or so, but more than that is
It's
not
going to start
really
hurting
normal.
too, because
really
it's
gonna
pushing
start
on
hurting.
those internal stitches.
Yes. And then you're not going to get as good result because
Right.
you might bust one of those diastasis stitches, or it's just going to push and stretch your skin that I just tried to tighten. So that does happen at times.
So when do people usually start feeling themselves again, starting to have less post-op visits, and they end with their ultimate outcome?
So after that, the first 2 weeks, I will let them go home for 2 weeks and see them at a month. And then I'll start increasing their activities based on what they're healing. So I have patients who are superstars. They come with very good health to begin with. They're very active. They're like the gym rats, right? That have had some excess skin. So they tend to recover, honestly, a little bit quicker. So at 4 weeks, I'm trying to reel them in because they're trying to go back and do stuff. And I'm trying to say, look, let's slowly get you back to your preoperative base level and routine. I say 6 to 8 weeks for you to go back to doing everything and anything you want to do without restrictions. But at that 1 month mark, if all your incisions are really well healed and you're doing well, then we'll start increasing slowly to get you back in 6 to 8 weeks. So that's what I would tell people to expect. So I'll see them at that month, and then I'll see them at the 3 month mark if they're very reliable. If there's something going on, or if I feel like they need a little bit more hand holding, and some people do.
Yeah.
They do. They want to be seen more frequently, and that's okay. And I can usually gauge the personality of that. Or if they're unsure as to when we're going to get them back to their preoperative like baseline, then I'll see them at 8 weeks. Just to make sure that they're okay with the plan. I'm okay with the plan. Maybe something wasn't like perfect. There's a part of the suture line where we don't know about. Their drain had to stay in a little bit longer. So, but most of the time I'll see them at 3 months, and I'll see them at the 6 month mark, and then at the 1 year mark. And if they're great, then that's when they're officially 100%
released.
done, released. But at 3 months, most people should be very, very close, like 95% close to what they're going to be for the rest of their lives. Now, there's the color of their incisions and all that might change, but the shape and all that, should be there.
And some a little bit inflammation still has a little bit of swelling, so they'll still go down some after that, but a majority, that's where you think that's where they sit, is about that 3 month mark.
I think so.
For buying clothes purposes and stuff.
For clothes purposes and all of that. When you look at just the natural wound healing, if you go look at a wound healing chart, the first 2 months, the body's just depositing scar. And then it's going to start remodeling that scar at about 3 months. So now you're at your remodeling stage. So I imagine you're only going to get better from here on out.
Right.
And your incisions are only going to get better from here on out. And if you start being active, you're going to metabolize a lot of things, and you're going to realize how much your shape is still going to change, because now your body can focus on excess fat or skin laxities in other areas. And that's where people see the benefit and the weight loss, right? Because things are going to improve so much because they're more active now. That overhang of skin is gone. They can wear the yoga pants.
No more restrictions.
Yeah. And they feel like that's not in their way. So they like going to the gym. They like walking. Their clothes fit so much better. Sometimes they have to buy new clothes, right?
Yeah.
So that's where I think most people are okay with what they're going to look like for us around the 3 to 6 month mark. I do combine tummy tucks with liposuction. I think it helps with the waist. Not everybody needs it, but it helps with the waist shaping, and it helps with that little muffin top. Mm-hmm. Because if you're flat in the front, but then you're flabby on the flanks, don't look so good. Nothing spills over. Well. Yeah, it doesn't match. Like nothing spilling over in the front of your jeans, but stuff spilling over in the back. So very traditionally, we'll do some flank liposuction with it. There's only a certain amount of liposuction you can do to the actual flaps that you're raising. Otherwise, the skin dies. But you can definitely be safe in doing some waist shaping and doing some flank liposuction. And if somebody's looking for a more athletic look, there are safe ways to kind of shape those flaps to almost look like you're giving somebody a six-pack.
Yeah, so etching.
Just doing some abdominal etching. Yeah, which I think is really cool. And some people like that look. You just gotta like let them know what the implications of that is. And there's very technical ways in which you can do that. So it's just not everybody that is.
I think I've only met one person that had their abs etched, but it looked really good.
Yeah, it looked really good. But I think it's a good technique that's out there. Not everybody knows about it. But if they're looking for that athletic look, we can try to deliver that too.
Okay.
Yeah.
Well, you're open for consults.
Yeah, I mean, I do love to do this operation, and I think patients are really highly satisfied. I'm satisfied because I think it's like just immediate gratification for me too. And I just want to put this plug-in in there for a mummy makeover. I think we might have mentioned it on the breast thing.
Yes, we did.
But a mummy makeover traditionally is a breast procedure added to a tummy tuck. So think about the things that we've talked about on the breast talk, for example, episode, and on this episode. And now you're combining 2 operations. So this is going to keep you in the operating room a little bit longer. The recovery might extend the timing a little bit more. And so, everything is sort of additive.
Right.
But again, usually if someone wants both breast and abdomen done at the same time, it is achievable within 5 to 6 hours for the majority of patients. And this is where it's important for you to really openly discuss your goals, how much time you have to recover, and making sure that you're really nutritionally optimized, medically optimized, so you don't have complications and have to return to surgery prematurely.
Perfect. Now, you can find Rosie and myself on our website at ppsd.com, especially if you're looking for a phone number to call and get consults. There's also emails on there to get to our specific offices. But I think I'll eventually get a tummy tuck at some point. I've had all the lipo, but, I'm coming to see you.
Okay. Well, I've been wrestling with my little skin too, but right now it's not bothering me too much. But I'm here for you.
All right.
And anybody else that's out there that's looking for that procedure, we're open for business and we love doing it, and we'll take excellent care of you.
All right. And then if you have the intratracheal rash that we were talking about, I'm open to seeing you.
Oh, yeah. See Andrew first.
I can get all that put in for you, get that taken care of, and then you can go see Rosie for the other half.
Yeah, that's right. All right. Well, I'm Dr. Rosie Roeder.
And I'm Andrea Spar.
We're the Rejuvenates Podcast, and we'll catch you next time.
And don't forget to like, comment, and subscribe below.
All right. Great.